Thank you for listening to this small video about the immunoglobulin domain 2. We know that passive immune therapies work in COVID-19 and has been shown within the recovery trial in patients who had no previous antibodies detected and also in outpatient therapies. There are multiple types of passive immune therapy, convalescent plasma being one of them, and this can adapt to viral variants, whereas monoclonal antibodies cannot. As you can see here. Here is a table of the various monoclonal immune therapies that have got licenses or emergency use authorization. All of these monoclonal antibodies now are resistant to multiple variants of Omicron, and their utility in the current era of new variants is very limited. So what is convalescent plasma? Convalescent plasma is plasma that's been donated by individuals who've recovered from an infection. Ideally, it contains high levels of antibodies against that infection that can provide passive immunity to any recipient. Plasma from donors who've been both vaccinated and had an infection of COVID-19 shows very high antibody levels, much higher than prior to the pre-vaccination era, and also that they have antibodies that cross-react with multiple variants of concern. So when we think about convalescent plasma in COVID-19 and looking back at the REMAP-CAP trial, we know that there was no overall evidence of effect of convalescent plasma. However, when we looked at subgroup of primary outcome, we saw that the immunocompromised subgroup did show that there was a potential benefit of convalescent plasma in those who are immunocompromised. We've looked at this again in other trials, and if you see here, when we put multiple trials together, there appears to be a benefit with decreased mortality in patients who are immunocompromised and receive convalescent plasma compared to those who do not. So what about the updated REMAP-CAP immunoglobulin domain? So our hypothesis is that treatment with high titer ABO compatible convalescent plasma from donors who've been vaccinated improves survival to hospital discharge with reduced use of ICU level organ support. Our inclusion criteria has changed from the previous version of the domain. They're adults with confirmed SARS-CoV-2 and either hospitalised on the ward or in ICU within 48 hours of ICU admission or 14 days of hospital admission with known immunosuppression. And we have a broad definition of that, which is compatible with the previous REMAP-CAP of an Apache Plus. We know that patients who have immunodeficiency, and around 500,000 people in England meet the criteria for immunodeficiency. The intervention is 2 adult units of high titer vaccinated convalescent plasma versus standard care, and a primary outcome of ordinal composite outcome of in-hospital mortality and number of days free of ICU level organ support up to day 21. Secondary outcomes are similar to the more general REMAP-CAP trial.